Good afternoon, everyone. And I would like to thank the organizers of this program for having invited me. Dr. Jose has already covered a part of my talk, so it makes things easier for me. And the other thing I noticed is during the last session, there were a lot of words being thrown around, like MIC, breakpoint, AUC, ARC, steady state, volume of distribution. Reminds us of our preclinical days, isn't it? When we never understood anything. Okay, this was thrust upon us. We had to pass our exams, so we mugged it up, wrote our exams. A lot of us got distinctions. Many of us just scraped through, and here we are, all as doctors, trying to figure out what all these mean. I'm going to use more of such words and confuse all of you all. Okay, now I'm trying to cover certain points. One will be, how do we actually come at an antibiotic dose? We are told to give a certain dose by the pharmaceutical company, whoever, and we use it. How do we come to it? Again, a reminder of the general pharmacology. I'll have a couple of slides on that. And Dr. Jose Jaco did mention about this, how the pharmacological characteristics are slightly different in a critically ill patient, and how that actually affects the dosing, and how our microbes, we have been talking about microbes, also affect it. And then how to optimize antibiotic dosing, this era of technology, and how we can do it actual way. And then I will try and say how I do it in my ICU with not all the technology that is available in the Western world. Okay. So this is what we get. We get an antibiotic. Immediately we look at the insert and see, Mirapanam, what dose do I give? That's there, and we start with that. So how do they come to this dose? How do they know this is the dose that they have to use? Okay, they go through a lot of process, okay, starting from animal studies all the way up when they come to a phase 4 trial. So the initial phases in the animal, the basics in vivo study, all your pharmacodynamics, pharmacokinetics, your PK, PD, AUC, or Cmax, all that is calculated. And then in phase 1, the study, they use it in healthy people, and that is used to look at the safety and tolerability. Pointer is missing. Sorry, I went back. There I got the pointer. So phase 1, it's looking at the tolerability, safety and tolerability. Okay. Is it here? Okay. And phase 2, phase 3 are actually to actually come at the efficacy and dose. Okay. Dose of the, where's the pointer in this? Thank you. Come at the dose. Okay. So it takes a long time to actually come to that, look at that, around 12 years before it comes out after phase 4 and we start using it. And let me remind you that all of these studies are looking at initially animals, then normal healthy volunteers, then people with the disease for which the antibiotic can be used but who are not critically ill. So what happens? Here you have a patient who gets attacked by a bug, and we give an antibiotic as per the dose. The antibiotic is absorbed, so if you give it IV, the whole thing gets into the system, gets distributed, metabolized, and then gets excreted. Now the dose depends on all these factors: the bioavailability, the volume of distribution, how it gets cleared, and how quickly it gets eliminated. So all these interactions in the body lead to what is known as the pharmacodynamics. Finally, determines the concentration of the antibiotic at the site of infection. So there's a lot of things to happen here, a lot of things happening here to finally come to this stage, and that's how we finally get that graph that all of us talk about, and that's how we kill the bug. But critically ill patient is a different animal by itself. So the pathophysiology alters all this. Volume of distribution changes, clearance changes, absorption might change, distribution will change. Because of all those changes, the concentration of your drug at the source of infection might also change, and to add it to all that, you most of the time get infected by a bug which is resistant or has a higher break point. So the initial dose which you see in the insert might not be enough. So we have to consider all this when we are treating the patient. Remember that the PK/PD graph in an IV injected drug would be like this, and not the classical bell-shaped curve that you are seeing. Okay, keep that at the back of mind. We have already gone through this. Which are the drugs that act as the peak? What are the drugs which act when it's at above the MIC? What are the drugs where you need the concentration, middle of the curve? All of us know all that. I'm not going to go through that. Most of these studies are done, I said, in vivo or in animals to arrive at these conclusions. So based on that, we have three groups of drugs. One is the type 1, which kills based on the concentration. It also has a prolonged persistent effect, and for such drugs you have to make sure that when you give a dose, the dose should have a this is the PK/PD, the Cmax by MIC optimized, and also a area under the type 2 is a time dependent killing. Okay, that's the beta lactams, where you have to make sure that it's the time above the MIC should always be high. And then you got the type 3, which is time dependent killing, which has a moderate to prolonged, where only the area under the curve. So keep that at the back of the mind. Again, I'll show you evidence that it's not only in vivo. There are clinical studies which have shown now that if you treat your patient and are able to achieve the PK/PD values, maybe you'll be able to kill the bugs better. Now, how are critically ill patients different? So these are things that we see very often in critically. They are in hyperdynamic circulation, interstitial fluid is more, they are hypoalbuminic, they have vascular dysfunction, they have renal dysfunction, there is pulmonary infection, they may be on extracorporeal circulation. So all this put together lead to the following problem. If your patient has a hyperdynamic circulation, cardiac output is high, GFR can be high, and renal clearance will be high. So they have an augmented renal clearance. So what happens if you give a standard dose, the plasma concentration can be low. If they have a high interstitial fluid, that's third spacing, the volume of distribution increases, so your drug gets diluted at all phases, and plasma concentration drops again. If you are hypoalbuminic, the drugs, especially those who are bound, gets unbound, and that again increases the volume of distribution because the drug moves to all spaces in the body, and again plasma concentration decreases. If you have a vascular dysfunction, blood flow to your target site might be decreased, and delivery of the drug to the area of infection will be decreased. If you have renal dysfunction, clearance is low, and plasma concentration of the drug, if you use a normal dose, would be high. So in nutshell, maybe if you use what we call as a standard dose, your patient who is critically ill may not receive an appropriate plasma concentration of the drug. So this is what actually happens. Increased volume of distribution in all these situations, decreased clearance in all this clearance, increased clearance here, and variable when they are on extracorporeal circulation. So most of our patients fall in this group, and how are we going to do that and achieve the correct dose? On top of that, we have bugs which are going to be persistent. okay, and most of them may not be resistant, may have a break near the break point, the MIC near the break point. Most of our ICUs just give us a report saying that it's susceptible, intermediate or resistant. It does not actually tell us where on the graph of the break point is the susceptibility or the sensitivity. It just tells us whether we can use the antibiotic or not. The best example is MRSA. All of you all would have heard of MRSA creep. MRSA is supposed to be susceptible if the MIC is less than 2 micrograms per milliliter. But there are studies to show that if from 0.5 the MIC climbs slowly to 1 and even it comes to 2, sometimes the normal recommended dose of vancomycin does not help. You have to use a higher dose. So unless we know the MIC or our lab is able to give us a regular follow-up on the MIC, we would not know what type of bug is there in our ICU. So knowing the MIC or the pathogen is useful. So a combination of altered PK, an infection with a pathogen which has maybe a slightly higher MIC going towards the upper end of susceptibility will lead to a failure in standard fixed regimen. That's what can happen. So how are you going to optimize it? So if you have everything in your lab and you can do any test you want, okay, what are you going to do? First, do things to try and optimize the PK/PD targets, which will give you the best antibiotic concentration. Okay, I'm not going to pick on everything. I just want to tell you that we have moved from the preclinical studies of PK/PD, and there are clinical studies to say tell us at what PK/PD levels the antibiotics would act. So, for example, aminoglycoside, your Cmax by MIC should be 8 to 10 times above the MIC, okay, and area under the curve should be greater than 70. Carbapenems, your time above the MIC should be at least more than 75%. Otherwise, it doesn't work. Okay, if you see here cephalosporins, it should be 100% of the time. Otherwise, it does not work. Vancomycin, area under the curve, AUC by MIC should be greater than 400 to 450. So these are the targets we are supposed to keep. So if you are going to use aminoglycoside, look for a Cmax by MIC. It should be at least 10 times that time above the MIC. Okay. If you are using vancomycin, the area under the graph should be greater than 400. If you are using carbapenems, depending on which if you're using beta-lactams, depending on which beta-lactam you're using, the time above MIC should be at least 50 to 100% of the time. That's what you're trying to aim. Okay. And there are studies to clearly show that if we give cephalosporin beta-lactams as a continuous infusion, we improve on the outcome, not on mortality. There's a trend towards increased mortality, but the studies have not shown increased mortality, but outcome, length of stay, duration on mechanical ventilation, achieving bug killing, all that improves. Okay. Now, the other thing we can do if we have the facility is to check the antibiotic level. Okay. Not done in most of our labs. If we can do it, there is a method by which there is software which you can put the drug level in the software, and the software tells us, what dose to use. Doses are just by the clinician based on the dosing software. I'll show you that, and that helps us to get a PK/PD right. So patient selection, sampling time, assay method all vary from drug to drug. So this involves having a very good lab trained personnel to give us this value. So it is at the moment not clinically feasible on the bedside. So if I have everything and I can get the drug level, how am I going to do it? Okay, first dose antibiotics given as a clinician's decision. So like what Joe said, think, do you want to use the antibiotic? If the answer is yes, appropriate dose. Use a strategy to achieve the PK/PD target. Then during the subsequent doses, you will take blood samples to look at the serum level, and they should be assayed quickly. No, don't keep them standing for long. Then collect the dosing history, drug concentration, necessary other patient data like weight, weight of the patient, creatinine clearance, everything, and then you enter it into a software. I'll tell you about the software. And with that, you should also know what is the possible MIC of the pathogen you are suspecting. Now, you put that into the software, and using a statistical method, it gives us the dose that we are supposed to use. And as I said, numerous programs are available. I tried logging into the website which said free, and they're free. I tried a couple of them. I could not actually put it in. So I think even though they say free, you have to actually do a payment or give your credit card details so that they allow you to get into it. So it's actually not fully free. Okay. So there are methods available if you have a good lab, access to a software to individualize dosing for sick patients. Then if you don't have it, how do you do it? I'm going to conclude with what we normally do in our ICU. Case scenario again, a patient, 26-year-old man, had a road traffic accident, polytrauma, his 8th day in the ICU, had a laparotomy for a damage control surgery. He was extubated, doing well, has a central line, now starts developing fever, warm peripheries, bounding pulse, heart rate is 120 per minute, and starts dropping his blood pressure to 80/40. As Joe said, asked, is this infection? Can you take out the line? If you think no, if you think it is a catheter related infection, the questions you are going to ask is, can you just remove the line and leave it long? Will you start antibiotic? If so, what antibiotic will you start? What is the most likely organism? You should know what would be after the first week in your ICU that you're going to see, and what antibiotic and what dose would you choose. Okay. In my ICU, I know after the first week what I'm going to see would be either a Klebsiella or a E. coli, and it's definitely going to be an ESBL. Yes, I will take out the line, and my choice will be a carbapenem. What dose will I give it? Young chap, good urine output. Where is that? Good. Bounding pulse, telling me hyperdynamic. So definitely is going to have an augmented renal clearance. So I'll give him a loading dose higher than the usual over 30 minutes. Then I'll follow it up with 1 gram thrice a day given as an infusion to try and achieve the PKD, PD parameters for beta lactams. I will collect the culture and sensitivity as quickly as possible because I would like to know whether it's sensitive bug or not. Usually after a week it would be meropenem sensitive, but you never know, and based on that change the antibiotics if required. Thank you.